Lewis's Medical Surgical Nursing, 11th edition, Chapter 49, Endocrine Problems. The endocrine system is made up of several organs and glands that are involved in the synthesis and secretion of hormones that affect every body system. Because hormones have a wide range of action, problems with the regulation are associated with homeostatic changes that can affect many aspects of a person's life. The severity varies widely. There may be adverse effects on perfusion, metabolism, and nutrition. Regulating fluid and electrolyte balance, skin integrity, and temperature may be difficult. The patient may have problems with growth and fertility and reproductive processes since these are hormone dependent. There may be a wide range of psychologic responses, including anxiety and depression. Disorders of anterior pituitary gland. The pituitary gland is considered the master gland of the endocrine system. The anterior pituitary gland secretes growth hormone, GH, prolactin, and tropic hormones. Adrenocorticotropic hormone, ACTH, thyroid stimulating hormone, TSH, follicle stimulating hormone, FSH, and luteinizing hormone, LH. These hormones affect growth, sexual maturation, reproduction, metabolism, stress response, and fluid balance. As a result, pituitary gland disorders manifest in a variety of ways. Tumors of the pituitary gland account for 5 to 20% of primary intracranial tumors. The most common, a pituitary adenoma, is a slow-growing, benign tumor. It often occurs in adults between 40 and 60 years of age. Hypersecretory pituitary adenomas secrete an excess of a specific hormone, causing manifestations related to the action of that hormone. The most common are prolactinomas and GH and ACTH secreting adenomas. Acromegaly. Acromegaly is a rare condition characterized by an overproduction of GH. Around 4 of every 1 million adults in the United States are diagnosed annually. It affects both genders equally. The mean age at the time of diagnosis is 40 to 45 years old. Etiology and pathophysiology. Acromegaly most often occurs because of a benign GH secreting pituitary adenoma. The excess GH results in an overgrowth of soft tissues and bones in the hands, feet, and face. Because the problem develops after epiphyseal closure, the bones of the arms and legs do not grow longer. Clinical manifestations. The changes resulting from excess GH in adults can occur slowly, over many years, and may go unnoticed by the person, family, and friends. Thickening and enlargement of the bony and soft tissues on the face, feet, and head occur. Patients may have proximal muscle weakness and joint pain that can range from mild to crippling. Carpal tunnel syndrome and peripheral neuropathy may be present. Tongue enlargement results in dental and speech problems. The voice deepens because of hypertrophy of the vocal cords. Sleep apnea may occur because of upper airway narrowing and obstruction from increased amounts of pharyngeal soft tissues. The skin becomes thick, leathery, and oily with acne outbreaks. Vision changes may occur from pressure on the optic nerve from a pituitary adenoma. Headaches are common. Since GH antagonizes the action of insulin, glucose intolerance and manifestations of diabetes may occur, including polydipsia, increased thirst, and polyuria, increased urination. The life expectancy of those with acromegaly is reduced by 5 to 10 years. They are prone to cardiovascular disease, diabetes, and colorectal cancer. Even if patients are cured or the disease is well controlled, manifestations such as joint pain and deformities often remain. Diagnostic studies. In addition to the history and physical examination, The diagnosis requires evaluating plasma insulin-like growth factor 1 (IGF-1) levels and GH response to an oral glucose tolerance test (OGTT). IGF-1 mediates the peripheral actions of GH. As GH levels rise, so does IGF-1 levels. Since GH is released in a pulsatile fashion, several samples are needed to obtain an accurate assessment. Serum IGF-1 levels are more constant, giving a more reliable diagnostic measure of acromegaly. During an OGTT, GH concentration normally falls because glucose inhibits GH secretion. In acromegaly, GH levels do not fall, and in some cases, GH levels rise. MRI or high-resolution CT scan with contrast media can detect pituitary adenomas. A complete eye examination, including visual fields, is done because a tumor may cause pressure on the optic chiasm or optic nerves. Interprofessional and nursing care. The patient's prognosis depends on the age at onset, age when treatment started, and tumor size. The overall goal is to return the patient's GH levels to normal. Treatment consists of surgery, radiation therapy, drug therapy, or a combination of these therapies. Treatment can stop bone growth and reverse tissue hypertrophy. However, sleep apnea, diabetes, and cardiac problems may persist. Surgery, hypophysectomy, is the treatment of choice. It offers the best chance for a cure and optimal symptom management, especially for smaller pituitary tumors. Surgery results in an immediate reduction in GH levels. IGF-1 levels fall within a few weeks. Patients with large tumors or those with GH levels greater than 45 nanograms per milliliter may need adjuvant radiation or drug therapy. Surgery and radiation therapy for pituitary tumors are discussed later in this chapter, page 1145. Drug therapy is an option for patients whose surgery did not result in a cure and or in combination with radiation therapy. The main drug used is octreotide, sandostatin, a somatostatin analog. It reduces GH levels to normal in many patients. Octreotide is given by subcutaneous injection 3 times a week. Long-acting somatostatin analogs, octreotide, sandostatin LAR, pasireotide, Signifor, and lanreotide SR, somatostatin depot, are available as IM injections given every 4 weeks. GH levels are measured every 2 weeks to guide drug dosing, and then every 6 months until the desired response is achieved. Dopamine agonists, e.g. bromocriptine, cabergoline, may be given alone or with somatostatin analogs if complete remission has not been achieved after surgery. These drugs reduce the secretion of GH from the tumor. GH antagonists, e.g. pegvisomant, somavert, reduce the effect of GH in the body by blocking liver production of IGF-1. Most patients taking this drug achieve normal IGF levels with symptom improvement. Serial photographs showing improvement in appearance may be helpful to the patient's recovery. Psychosocial effects of acromegaly include body image problems, sexual problems, and depression. Fatigue and sleep problems may persist after surgery. Patients will need strategies for dealing with these symptoms. Referral to a support group may be helpful. Excesses of other tropic hormones. Excess secretion of prolactin, or the tropic hormones, e.g. ACTH, TSH, by the anterior pituitary gland will cause other endocrine glands to overproduce certain hormones. In excess, of these hormones, discussed later in the chapter, can cause significant problems in metabolism and general health. A prolactin secreting adenoma is known as a prolactinoma. They account for about 40% of pituitary tumors. Women with prolactinomas may have galactorrhea, anovulation, infertility, infrequent or absent menses, decreased libido, and hirsutism. In men, impotence, decreased sperm density, and libido may result. Compression of the optic chiasm can cause vision changes and signs of increased intracranial pressure, including headache, nausea, and vomiting. Because prolactinomas do not typically progress in size, drug therapy is usually the first line treatment. The dopamine agonists, cabergoline and bromocriptine, are given to block the release of prolactin. Surgery may be an option, depending on the extent and size of the tumor. Radiation therapy can reduce the risk for tumor recurrence for patients with large tumors. Hypofunction of pituitary gland. Hypopituitarism is a rare disorder that involves a decrease in one or more of the pituitary hormones. A deficiency of only one pituitary hormone is called selective hypopituitarism. Total failure of the pituitary gland results in deficiency of all pituitary hormones, a condition referred to as panhypopituitarism. The most common hormone deficiencies associated with hypopituitarism involve GH and gonadotropins, e.g., LH, FSH. Etiology and pathophysiology. The usual cause of pituitary hypofunction is a pituitary tumor. Autoimmune disorders, infections, pituitary infarction, Sheehan syndrome, or destruction of the pituitary gland from trauma, radiation, or surgical procedures can also cause hypopituitarism. Blacks have a higher incidence of pituitary tumors than other ethnic groups. Anterior pituitary hormone deficiencies can lead to end organ failure. TSH and ACTH deficiencies are life-threatening. ACTH deficiency can lead to acute adrenal insufficiency and hypovolemic shock from sodium and water depletion. Clinical manifestations and diagnostic studies. The manifestations vary with the type and degree of dysfunction. Early manifestations associated with a space-occupying lesion include headaches, vision changes, decreased visual acuity or decreased peripheral vision, loss of smell, nausea and vomiting, and seizures. Manifestations associated with hyposecretion of the target glands vary widely. In addition to a history and physical examination, diagnostic studies such as MRI and CT can identify a pituitary tumor. Laboratory tests generally involve the direct measurement of pituitary hormones, e.g. TSH, or an indirect determination of the target organ hormones, e.g. T3, T4. Interprofessional and nursing care. The treatment for hypopituitarism often consists of surgery or radiation therapy, followed by lifelong hormone therapy. Surgery and radiation therapy for pituitary tumors are discussed in the next section. Appropriate hormone therapy is used, e.g., GH, corticosteroids, thyroid hormone. Hormone therapies for thyroid hormone and corticosteroids are discussed later in the chapter. Somatropin, genotropin, humatrope, omnitrope. Recombinant human GH is used for long-term hormone therapy in adults with GH deficiency. These patients respond well to GH replacement, have increased energy, increased lean body mass, a feeling of well-being, and improved body image. Mild to moderate side effects of GH include fluid retention with swelling in the feet and hands, myalgia, joint pain, and headache. GH is given daily as a subcutaneous injection, preferably in the evening. The dosing is variable and adjusted based on symptoms, IGF-1 levels, and the presence of adverse effects. Although gonadal deficiency is not life-threatening, hormone therapy will improve sexual function and general well-being. It is contraindicated in those with certain medical conditions such as phlebitis, pulmonary embolism, breast cancer in women, and prostate cancer in men. Estrogen and progesterone replacement therapy may be given to hypogonadal women to treat hot flashes, vaginal dryness, and decreased libido. Testosterone is used to treat men with gonadotropin deficiency. The benefits achieved with testosterone therapy include a return of male secondary sex characteristics, improved libido, and increased muscle mass, and bone density. Pituitary surgery. A hypophysectomy is the surgical removal of the pituitary gland. It is the treatment of choice for tumors in the pituitary area, especially smaller pituitary adenomas. Most surgeries are done by an endoscopic transsphenoidal approach. When the entire pituitary gland is removed, there is permanent loss of all pituitary hormones. The patient will need lifelong replacement therapy of thyroid hormones, sex hormones, and glucocorticoids. Radiation therapy can reduce the size of a tumor before surgery. It is also used when surgery does not produce a cure or when patients are poor candidates for surgery. Its full effects may not be noted for months to years. Radiation therapy may lead to hypopituitarism, which then requires lifelong hormone replacement therapy. Stereotactic radiosurgery, gamma knife surgery, proton beam, linear accelerator is an option for small, surgically inaccessible pituitary tumors or in place of conventional radiation. Nursing management, pituitary surgery. After surgery, assess the patient for the formation of a hematoma compressing the optic nerve or optic chiasma. Monitor peripheral vision, visual acuity, extraocular movements, and pupillary response. Report changes at once because prompt intervention may prevent visual deterioration from becoming permanent. Cerebrospinal fluid, CSF, leaks, and epistaxis are other common complications after surgery. The HCP may place a petroleum jelly-coated ribbon of gauze or a balloon-tipped catheter, like an indwelling urinary catheter, in the sphenoid sinus. It is usually removed after 24 hours. It can be left in for 2 to 3 days if there is a concern for bleeding or CSF leak. It is important that the patient does not blow the nose for at least 48 hours after surgery and avoids vigorous coughing, sneezing, and straining at stool. Monitor the mustache dressing regularly for any drainage. Check any clear drainage with a urine dipstick for glucose and protein. If present, notify the HCP of a possible CSF leak. A sample can be sent to the laboratory. A glucose level greater than 30 milligrams per deciliter indicates CSF leakage from an open connection with the brain. If this happens, the patient is at increased risk for meningitis. A persistent and severe generalized or supraorbital headache may indicate CSF leakage into the sinuses. A CSF leak usually resolves within 72 hours when treated with head elevation and bed rest. If the leak persists, daily spinal taps may be done to reduce pressure to below normal levels. Other measures include elevating the head of the patient's bed at all times to a 30-degree angle. This avoids pressure on the sella turcica and decreases headaches. Monitor the pupillary response, speech patterns, and extremity strength to detect neurologic complications. Gentle mouth care every 4 hours is essential to keep the surgical area clean and free of debris. Have the patient avoid toothbrushing for at least 10 days to protect the suture line. Fluid and electrolyte problems can occur from the development of diabetes insipidus, DI. Transient DI may occur because of the loss of antidiuretic hormone, ADH, which is stored in the posterior lobe of the pituitary gland, or cerebral edema related to manipulation of the pituitary during surgery. DI may be permanent after surgery. To assess for DI, closely monitor urine output and measure specific gravity. Report a urine output of more than 200 milliliters per hour for more than 3 consecutive hours, or a specific gravity level of greater than 1.005. Patients with DI will have a high serum sodium and extreme thirst. DI is treated by giving desmopressin acetate, DDAVP. Fluid replacement may be needed to avoid hypovolemia related to high urine output. Syndrome of inappropriate antidiuretic hormone secretion, SIADH, can occur after any intracranial surgery. SIADH typically occurs later than DI, usually around the fourth postoperative day. It may occur due to manipulation of the pituitary and other structures, causing release of ADH. The fluid retention caused by circulating ADH leads to dilutional hyponatremia. Sodium levels of less than 125 MEq per liter will manifest as headache, vomiting, and decreased level of consciousness. The manifestations and treatment of DI and SIADH are discussed in the next section. ADH, cortisol, and thyroid hormone replacement are needed after a hypophysectomy. Teach the patient about the need for lifelong therapy. Surgery may result in permanent loss or deficiencies in FSH and LH. This can lead to decreased fertility. Assist the patient in working through the grieving process associated with these losses. Disorders of posterior pituitary gland. The hormones secreted by the posterior pituitary are ADH and oxytocin. ADH, also referred to as arginine vasopressin, AVP, or vasopressin, has a key role in the regulation of water balance and serum osmolarity. The primary problems associated with ADH secretion are a result of either overproduction or underproduction of ADH. Syndrome of inappropriate antidiuretic hormone. Etiology and pathophysiology. SIADH results from an overproduction of ADH or the release of ADH despite normal or low plasma osmolarity. ADH increases the permeability of the renal distal tubule and collecting duct, which leads to the reabsorption of water into the circulation. Extracellular fluid volume expands, plasma osmolality declines, the glomerular filtration rate increases, and sodium levels decline, dilutional hyponatremia. Thus, features of the disorder are fluid retention, serum hypoosmolality, dilutional hyponatremia, hypochloremia, and concentrated urine in the presence of normal or increased intravascular volume. SIADH occurs more often in older adults. The most common cause is cancer, especially small cell lung cancer. SIADH tends to be self-limiting when caused by head trauma or drugs. It can be chronic when associated with tumors or metabolic diseases. Clinical manifestations and diagnostic studies. The patient with SIADH has low urine output and increased body weight. At first, the patient has thirst, dyspnea on exertion, and fatigue. Mild hyponatremia causes muscle cramping, irritability, and headache. As the serum sodium level falls, usually below 120 milliequivalents per liter, manifestations become more severe and include vomiting, abdominal cramps, and muscle twitching. As plasma osmolality and serum sodium levels continue to decline, cerebral edema may occur, leading to lethargy, confusion, seizures, and coma. The diagnosis is made by simultaneous measurements of urine and serum osmolality. Dilutional hyponatremia is indicated by a serum sodium level less than 135 milliequivalents per liter, serum osmolality less than 280 milliosmoles per kilogram, and urine specific gravity greater than 1.030. A serum osmolality much lower than the urine osmolality shows the body is inappropriately excreting concentrated urine in the presence of dilute serum. Interprofessional and nursing care. When assessing patients at risk and those who have confirmed SIADH, be alert for low urine output with a high specific gravity, a sudden weight gain without edema, or a decreased serum sodium level. Monitor intake and output, vital signs, and heart and lung sounds. Obtain daily weights. Observe for signs of hyponatremia, including seizures, headache, vomiting, and decreased neurologic function. Once SIADH is diagnosed, treatment is directed at the underlying cause. Medications that stimulate ADH release should be avoided or discontinued. If symptoms are mild and serum sodium is greater than 125 milliequivalents per liter, the only treatment may be a fluid restriction of 800 to 1000 milliliters per day. This restriction should result in weight reduction and a gradual rise in serum sodium concentration and osmolality. An improvement in symptoms should accompany normalization of serum sodium and osmolality. Provide the patient with frequent oral care and distractions to decrease discomfort related to thirst from the fluid restriction. A loop diuretic, such as furosemide, Lasix, may be used to promote diuresis. The serum sodium must be at least 125 milliequivalents per liter because it may promote further sodium loss. Because furosemide increases potassium, calcium, and magnesium losses, supplements may be needed. Demaclocycline also may be given. This drug blocks the effect of ADH on the renal tubules, resulting in more dilute urine. Initiate seizure and fall precautions if the patient has an altered sensorium or is having seizures. Position the head of the bed flat or elevated no more than 10 degrees. This enhances venous return to the heart and increases left atrial filling pressure, thus reducing the release of ADH. Frequent turning, positioning, and range of motion exercises are important to maintain skin integrity and joint mobility. In cases of severe hyponatremia, less than 120 milliequivalents per liter, especially in the presence of neurologic manifestations such as seizures, small amounts of IV hypertonic saline solution, 3% sodium chloride, may be slowly given. It is important to correct hyponatremia slowly. The level should not increase by more than 8 to 12 milliequivalents per liter in the first 24 hours. Quickly increasing levels can cause osmotic demyelination syndrome with permanent damage to nerve cells in the brain. A fluid restriction of 500 milliliters per day may be needed for those with severe hyponatremia. Vasopressor receptor antagonists, drugs that block the activity of ADH, are used to treat euvolemic hyponatremia in hospitalized patients. Two drugs are FDA approved: conivaptan, vaprazole, and tolvaptan, Samska. Conivaptan is given IV. Tolvaptan is given orally. Neither should be given to patients with liver disease because they worsen liver functions. Help the patient with chronic SIADH in self-managing the treatment plan. In chronic SIADH, a fluid restriction of 800 to 1,000 milliliters per day is recommended. Ice chips or sugarless chewing gum help decrease thirst. Have the patient obtain a daily weight to monitor changes in fluid balance. Have the patient supplement the diet with sodium and potassium, especially if taking loop diuretics. Teach the patient the symptoms of fluid and electrolyte imbalances, particularly those involving sodium and potassium. Diabetes insipidus, etiology and pathophysiology. DI is caused by a deficiency of production or secretion of ADH or a decreased renal response to ADH. The decrease in ADH results in fluid and electrolyte imbalances caused by increased urine output and increased plasma osmolality. Depending on the cause, DI may be transient or a chronic, lifelong condition. There are several types of DI. Central DI is the most common form. Clinical manifestations. Key features of DI are polydipsia and polyuria. The patient excretes large quantities of urine, 2 to 20 liters per day, with a very low specific gravity, less than 1.005, and urine osmolality of less than 100. Serum osmolality is increased, usually greater than 295, because of hypernatremia. Serum sodium greater than 145, caused by pure water loss in the kidneys. Most patients compensate for fluid loss by drinking large amounts of water so that serum osmolality stays normal or is moderately increased. The patient may be tired from nocturia and have generalized weakness. Uncorrected hypernatremia can cause brain shrinkage and intracranial bleeding. The onset of central DI is usually acute and accompanied by excess fluid loss. After intracranial surgery, central DI has a triphasic pattern. 1. An acute phase with an abrupt onset of polyuria. 2. An interphase in which urine volume normalizes. And 3. A third phase in which central DI may become permanent. The third phase occurs 10 to 14 days after surgery. Central DI from head trauma is often self-limiting and improves with treatment of the underlying problem. Although the manifestations of nephrogenic DI are less like those of central DI, the onset and amount of fluid loss are less dramatic. Severe dehydration can result if oral fluid intake cannot keep up with urinary losses. The patient will have hypotension, tachycardia, and hypovolemic shock. Increasing serum osmolality and hypernatremia can cause central nervous system (CNS) manifestations ranging from irritability and mental dullness to coma. Diagnostic studies. Patients with DI excrete dilute urine at a rate greater than 200 milliliters per hour with a specific gravity of less than 1.005. Central DI is diagnosed by a water deprivation test. Before the test, body weight and urine osmolality, volume, and specific gravity are measured. The patient is deprived of water for 8 to 12 hours and then given desmopressin acetate, DDAVP, subcutaneously or nasally. Patients with central DI have a dramatic increase in urine osmolality from 100 to 600 and a significant decrease in urine volume. The patient with nephrogenic DI will not be able to increase urine osmolality to greater than 300. Another test to distinguish central DI from nephrogenic DI is to measure the level of ADH after an analog of ADH, e.g., desmopressin, is given. If the cause is central DI, the kidneys will respond to the hormone by concentrating urine. If the kidneys do not respond in this way, the cause is nephrogenic. Interprofessional and nursing care. Management of the patient with DI includes early detection, maintaining adequate hydration, and patient teaching for long-term management. A therapeutic goal is maintaining fluid and electrolyte balance. For central DI, fluid and hormone therapy are the cornerstone of treatment. Fluids are replaced orally or IV, depending on the patient's condition and ability to drink copious amounts of fluids. In acute DI, IV hypotonic saline, or dextrose 5% in water, D5W, is given and titrated to replace urine output. If IV glucose solutions are used, monitor serum glucose levels because hyperglycemia and glycosuria can lead to osmotic diuresis, which increases the fluid volume deficit. Monitoring BP, heart rate, urine output, level of consciousness, and specific gravity is essential and may be done hourly in the acutely ill patient. Assess for signs of acute dehydration. Maintain an accurate record of intake and output and daily weights to determine fluid volume status. Adjustments in fluid replacement should be made accordingly. DDAVP, an analog of ADH, is the hormone replacement of choice for central DI. Another ADH replacement drug is aqueous vasopressin. DDAVP can be given orally, IV, subcutaneously, or as a nasal spray. Assess the response to DDAVP by monitoring pulse, BP, level of consciousness, intake and output, and specific gravity. Chlorpramide and carbamazepine, Tegretol, can help decrease thirst associated with central DI. Because the kidney is unable to respond to ADH in nephrogenic DI, hormone therapy has little effect. Instead, the treatment includes a low-sodium diet and thiazide diuretics, e.g., hydrochlorothiazide, chlorothiazide, diuryl, which may reduce flow to the ADH-sensitive distal nephrons. Limiting sodium intake to no more than 3 grams per day often helps decrease urine output. If a low-sodium diet and thiazide drugs are not effective, indomethacin, Indocin, may be prescribed. Indomethacin, a nonsteroidal anti-inflammatory drug, helps increase renal responsiveness to ADH. Disorders of thyroid gland. Problems with thyroid function are among the most common endocrine disorders. The thyroid hormones, thyroxine, T4, and triiodothyronine, T3, regulate energy metabolism and growth and development. Disorders of the thyroid gland include goiter, benign and malignant nodules, inflammatory conditions leading to hyperthyroidism, and hypothyroidism. A goiter is an enlarged thyroid gland. In a person with a goiter, the thyroid cells are stimulated to grow. This may result in an overactive thyroid, hyperthyroidism, or an underactive thyroid, hypothyroidism. The most common cause of goiter worldwide is a lack of iodine in the diet. In the United States, where most people use iodized salt, goiter is more often due to the overproduction or underproduction of thyroid hormones or to nodules that develop in the gland itself. Goitrogens, foods or drugs that contain thyroid inhibiting substances, can cause a goiter. A non-toxic goiter is a diffuse enlargement of the thyroid gland that does not result from cancer or an inflammatory process. Normal levels of thyroid hormone are associated with this type of goiter. Nodular goiters are thyroid hormone secreting nodules that function independent of TSH stimulation. There may be multiple nodules, multinodular goiter, or a single nodule, solitary autonomous nodule. The nodules are usually benign follicular adenomas. If these nodules are associated with hyperthyroidism, they are called toxic nodular goiters. This type of goiter is often found in patients with Graves' disease. Toxic nodular goiters occur equally in men and women. Although they can appear at any age, they most often occur in people over 40 years of age. TSH and T4 levels are measured to determine whether a goiter is associated with normal thyroid function, hyperthyroidism, or hypothyroidism. Thyroid antibodies, e.g., thyroid peroxidase (TPO) antibody, show the presence of thyroiditis, inflammation of the thyroid. Treatment with thyroid hormone may prevent further thyroid enlargement. Surgery can remove large goiters. Goiter as a manifestation of thyroid disorders is discussed in the next sections. Thyroiditis. Thyroiditis, an inflammation of the thyroid gland, encompasses several clinical disorders. It is a frequent cause of goiter. Subacute granulomatous thyroiditis is thought to be caused by a viral infection. Acute thyroiditis is due to bacterial or fungal infection. Subacute and acute forms of thyroiditis have an abrupt onset. The patient reports pain localized in the thyroid or radiating to the throat, ears, or jaw. Systemic manifestations include fever, chills, sweats, and fatigue. Hashimoto's thyroiditis, chronic autoimmune thyroiditis, is caused by the destruction of thyroid tissue by antibodies. It is the most common cause of hypothyroid goiters in the United States. Risk factors include female gender, a positive family history, older age, and white ethnicity. The goiter, which is the hallmark of Hashimoto's thyroiditis, may develop gradually or rapidly. If it enlarges rapidly, it may compress structures in the neck, e.g., trachea, laryngeal nerves, changing the voice and affecting breathing. As thyroid tissue is destroyed by antibodies, there may be a transient phase of hyperthyroidism due to leaking thyroid hormone from the damaged tissues. Silent painless thyroiditis, which may be early Hashimoto's thyroiditis, can occur in postpartum women. This condition is usually seen in the first 6 months after delivery. It may be due to an autoimmune reaction to fetal cells in the mother's thyroid gland. T4 and T3 levels are initially increased in subacute, acute, and silent thyroiditis, but become decreased with time. Suppressed radioactive iodine uptake, RAIU, is seen in subacute and silent thyroiditis. In Hashimoto's thyroiditis, T4 and T3 levels are usually low and the TSH level is high. Antithyroid antibodies are present in Hashimoto's thyroiditis. Recovery from acute or subacute thyroiditis may be complete in weeks or months without any treatment. If the thyroiditis is bacterial in origin, treatment may include specific antibiotics or surgical drainage. In the subacute and acute forms, NSAIDs are used to relieve symptoms. With more severe pain, corticosteroids, e.g. prednisone, up to 40 milligrams per day, can release discomfort. Propanolol, Inderol, or atenolol, Tenormin, may relieve cardiovascular symptoms related to a hyperthyroid condition. The patient who is hypothyroid needs thyroid hormone therapy. Nursing care of the patient with thyroiditis includes patient teaching about the disease process and course of treatment. Teach the patient not to stop medications abruptly. Tell the patient to remain under close healthcare supervision so that progress can be monitored. Teach the patient to report to the HCP any change in symptoms, such as difficulty breathing or swallowing, swelling to face and extremities, or rapid weight gain or loss. Teach those receiving thyroid hormone about the expected side effects of these drugs and ways to manage them. The patient with Hashimoto's thyroiditis is at risk for other autoimmune diseases such as Addison's disease, pernicious anemia, or Graves' disease. Teach the patient the signs and symptoms of these disorders, particularly Addison's disease. Hyperthyroidism. Hyperthyroidism is hyperactivity of the thyroid gland with sustained increase in synthesis and release of thyroid hormones. It occurs in women more than men, with the highest frequency in persons 20 to 40 years old. The most common form is Graves' disease. Other causes include toxic nodular goiter, thyroiditis, excess iodine intake, pituitary tumors, and thyroid cancer. Since hyperthyroidism may be caused by iodinated contrast media used in CT scans and other radiologic studies, monitor those who are at risk closely after iodinated contrast media exposure. The term thyrotoxicosis refers to the physiologic effects or clinical syndrome of hypermetabolism resulting from excess circulating levels of T4, T3, or both. Hyperthyroidism and thyrotoxicosis usually occur together. Subclinical hyperthyroidism occurs when the patient has a serum TSH level below 0.4 milliunits per liter, but normal T4 and T3 levels. Overt hyperthyroidism is defined by low or undetectable TSH and increased T4 and T3 levels. The patient may or may not have symptoms of hyperthyroidism. Etiology and pathophysiology. Graves' disease. Graves' disease is an autoimmune disease of unknown cause, characterized by diffuse thyroid enlargement and excess thyroid hormone secretion. It accounts for 75% of the cases of hyperthyroidism. Causative factors such as a lack of iodine, smoking, infection, and stressful life events may interact with genetic factors to cause Graves' disease. In Graves' disease, the patient develops antibodies to the TSH receptor. These antibodies attach to the receptors and stimulate the thyroid gland to release T3, T4, or both. The excess release of thyroid hormones leads to the manifestations associated with thyrotoxicosis. The disease is characterized by remissions and exacerbations, with or without treatment. It may progress to destruction of the thyroid tissue, causing hyperthyroidism. Graves' disease is associated with the presence of other autoimmune disorders, including rheumatoid arthritis, pernicious anemia, systemic lupus erythematosus, Addison's disease, celiac disease, and vitiligo. Clinical manifestations. The manifestations are related to the effect of excess circulating thyroid hormone. It directly increases metabolism and tissue sensitivity to sympathetic nervous system stimulation. Palpation of the thyroid gland may reveal a goiter. When the thyroid gland is excessively large, a goiter may be seen on inspection. Auscultating the thyroid gland may reveal bruits, a reflection of increased blood supply. Another common finding is Ophthalmopathy, a term used to describe abnormal eye appearance or function. A classic finding in Graves' disease is exophthalmos, a protrusion of the eyeballs from the orbits that is usually bilateral. Exophthalmos results from increased fat deposits and fluid edema in the orbital tissues and ocular muscles. The increased pressure forces the eyeballs outward. The upper lids are usually retracted and elevated, with the sclera visible above the iris. When the eyelids do not close completely, the exposed corneal surfaces become dry and irritated. Corneal ulcers and loss of vision can occur. Changes in the ocular muscles result in muscle weakness, causing diplopia. Other manifestations are outlined in Table 49.6. Abnormal laboratory findings are listed in Table 49.7. A patient in the early stages of hyperthyroidism may only have weight loss and increased nervousness. Acropatchy, clubbing of the digits, may occur with advanced disease. Manifestations, e.g. palpitations, tremors, weight loss, in older adults do not differ significantly from those of younger adults. In older patients who are confused and agitated, dementia may be suspected and delay the diagnosis. Complications. Acute thyrotoxicosis, also called thyrotoxic crisis or thyroid storm, is an acute, severe, and rare condition that occurs when excess amounts of thyroid hormones are released into the circulation. Although considered a life-threatening emergency, death is rare when treatment is started early. Acute thyroiditis is thought to result from stressors, e.g. infection, trauma, surgery, in a patient with pre-existing hyperthyroidism. Patients having a thyroidectomy are at risk because manipulation of the hyperactive thyroid gland results in an increase in hormones released. In acute thyrotoxicosis, all the symptoms of hyperthyroidism are prominent and severe. Manifestations include severe tachycardia, heart failure, shock, hyperthermia up to 106 Fahrenheit, agitation, delirium, seizures, abdominal pain, vomiting, diarrhea, and coma. Diagnostic studies. The primary laboratory findings used to confirm the diagnosis of hyperthyroidism are low or undetectable TSH levels, less than 0.4 milliunits per liter, and increased free thyroxine, free T4 levels. Total T3 and T4 levels also may be assessed, but they are not as definitive. Total T3 and T4 determine both free and bound to protein hormone levels. The free hormone is the only biologically active form of these hormones. The RAIU test can distinguish Graves' disease from other forms of thyroiditis. The patient with Graves' disease shows a diffuse, homogeneous uptake of 35 to 95%, while the patient with thyroiditis shows an uptake of less than 2%. The person with a nodular goiter has an uptake in the high normal range. Interprofessional care. The goal of management is to block the adverse effects of excess thyroid hormone, suppress oversecretion of thyroid hormone, and prevent complications. There are several treatment options, including anti-thyroid medications, radioactive iodine therapy, and surgical intervention. Supportive therapy is directed at managing respiratory distress, reducing fever, replacing fluid, and eliminating or managing the initiating stressors. The choice of treatment is influenced by the patient's age and preferences, coexistence of other diseases, and pregnancy status. Drug therapy. Drugs used to treat hyperthyroidism include anti-thyroid drugs, iodine, and beta-adrenergic blockers. These drugs are useful in treating thyrotoxic states, but are not curative. Radiation therapy or surgery may be needed. Antithyroid drugs. The first line antithyroid drugs are propylthiouracil and methimazole, tapazole. These drugs inhibit thyroid hormone synthesis. Reasons for use include Graves' disease in the young patient, hyperthyroidism during pregnancy, and the need to achieve a euthyroid state before surgery or radiation therapy. Propylthiouracil is generally used for patients who are in the first trimester of pregnancy, had an adverse reaction to methimazole, or need a rapid reduction in symptoms. It is the first-line therapy in thyrotoxicosis since it blocks the peripheral conversion of T4 to T3. An advantage of propylthiouracil is that it achieves the therapeutic goal of being euthyroid more quickly. However, it must be taken 3 times per day. Methimazole is given in a single daily dose. Improvement usually begins 1 to 2 weeks after the start of drug therapy. Results are usually seen within 4 to 8 weeks. Therapy is usually continued for 6 to 15 months to allow for spontaneous remission, which occurs in 20 to 40% of patients. Emphasize to the patient the importance of adhering to the drug plan. Abruptly stopping drug therapy can result in a return of hyperthyroidism. Iodine. Iodine is available as saturated solution of potassium iodine, SSKI, and Lugol's solution. Iodine is used with other antithyroid drugs to prepare the patient for thyroidectomy or for treatment of thyrotoxicosis. Rapidly giving large doses of iodine inhibits synthesis of T3 and T4 and blocks the release of these hormones into circulation. It also decreases the vascularity of the thyroid gland, making surgery safer and easier. The maximal effect is usually seen within 1 to 2 weeks. Because of a reduction in the therapeutic effect, long-term iodine therapy is not effective in controlling hyperthyroidism. Iodine is mixed with water or juice and given after meals. Sipping it through a straw decreases the chances of it staining the teeth. Assess the patient for signs of iodine toxicity, such as swelling of the buccal mucosa and other mucous membranes, excess salivation, nausea and vomiting, and skin reactions. If toxicity occurs, stop administering iodine and notify the HCP. Beta-adrenergic blockers. Beta blockers are used for symptomatic relief of thyrotoxicosis. These drugs block the effects of sympathetic nervous stimulation, thereby decreasing tachycardia, nervousness, irritability, and tremors. Propranolol is usually given with antithyroid agents. Atenolol is the preferred beta blocker for use in the hyperthyroid patient with asthma or heart disease. Radioactive iodine therapy. Radioactive iodine (RAI) therapy is the treatment of choice for most non-pregnant adults. RAI damages or destroys thyroid tissue, thus limiting thyroid hormone secretion. RAI has a delayed response. The maximum effect may not be seen for up to 3 months. For this reason, the patient is usually treated with antithyroid drugs and propranolol before and for 3 months after starting RAI until the effects of radiation become apparent. Although RAI is usually effective, 80% of patients have post-treatment hypothyroidism, resulting in the need for lifelong thyroid hormone therapy. Teach the patient the symptoms of hypothyroidism and to seek medical help if these symptoms occur. RAI therapy is usually given on an outpatient basis. A pregnancy test is done before starting therapy for all women who have menstrual cycles. Tell the patient that radiation thyroiditis and parotitis are possible and may cause dryness and irritation of the mouth and throat. Relief may be obtained with frequent sips of water, ice chips, or a salt and soda gargle 3 or 4 times per day. This gargle is made by dissolving 1 teaspoon of salt and 1 teaspoon of baking soda in 2 cups of warm water. The discomfort should subside in 3 to 4 days. A mixture of antacid, Mylanta or Maalox, diphenhydramine, and viscous lidocaine can be used to swish and spit, increasing patient comfort when eating. To limit radiation exposure to others, teach the patient receiving RAI home precautions, including 1. Using private toilet facilities, if possible, and flushing 2 or 3 times after each use. 2. Separately laundering towels, bed linens, and clothes daily at home. 3. Not preparing food for others that requires prolonged handling with bare hands. And 4. Avoiding being close to pregnant women and children for 7 days after therapy. Surgical therapy. A thyroidectomy is done for those who have 1. A large goiter causing tracheal compression, 2. A lack of response to anti-thyroid therapy, or 3. Thyroid cancer. Surgery may be done when a person is not a candidate for RAI. One advantage that thyroidectomy has over RAI is a more rapid reduction in T3 and T4 levels. A subtotal thyroidectomy is the preferred surgical procedure. It involves removing a significant portion, 90%, of the thyroid gland. Some patients may undergo minimally invasive endoscopic or robotic thyroidectomy. Endoscopic thyroidectomy is appropriate for patients with small nodules less than 3 centimeters and no evidence of cancer. Robotic surgery is best for those who are not overweight and have small nodules on only one side of the gland. Advantages of endoscopic and robotic procedures over open thyroidectomy include less scarring, less pain, and a faster return to normal activity. Nutritional therapy. With the increased metabolic rate in hyperthyroid patients, there is a high potential for the patient to have nutrition problems. A high-calorie diet, 4,000 to 5,000 calories per day, may be needed to satisfy hunger, prevent tissue breakdown, and decrease weight loss. This can be achieved with 6 full meals a day and snacks high in protein, carbohydrates, minerals, and vitamins. The protein content should be 1 to 2 grams per kilogram of ideal body weight. Increase carbohydrate intake to compensate for increased metabolism. Carbohydrates provide energy and decrease the use of body-stored protein. Teach the patient to avoid highly seasoned and high-fiber foods because they can further stimulate the already hyperactive GI tract. Have the patient avoid caffeine-containing liquids such as coffee, tea, and cola to decrease the restlessness and sleep problems. Refer the patient to a dietitian for help in meeting individual nutritional needs. Nursing management. Hyperthyroidism. Nursing assessment. Subjective and objective data you should obtain from a person with hyperthyroidism are outlined in Table 49.10. Nursing diagnoses. Nursing diagnoses for the patient with hyperthyroidism include activity intolerance, impaired nutritional status. Planning. The overall goals are that the patient with hyperthyroidism will 1. Have relief of symptoms, 2. Have no serious complications related to the disease or treatment, 3. Maintain nutritional balance, and 4. Cooperate with the therapeutic plan. Nursing implementation. Acute care. Patients with hyperthyroidism are usually treated in an outpatient setting. However, Those who develop acute thyrotoxicosis or undergo thyroidectomy need hospitalization and acute care. Acute thyrotoxicosis. Acute thyrotoxicosis requires aggressive treatment, often in an ICU. Give medications previously discussed that block thyroid hormone production and the sympathetic nervous system. Provide supportive thyroid, including monitoring for dysrhythmias and decompensation, ensuring adequate oxygenation, and giving IV fluids to replace fluid and electrolyte losses. This is especially important in the patient who has fluid losses from vomiting and diarrhea. Ensuring adequate rest may be a challenge because of the patient's irritability and restlessness. Provide a calm, quiet room because increased metabolism and sensitivity of the sympathetic nervous system causes sleep problems. Other interventions may include 1. Placing the patient in a cool room away from very ill patients and noisy high traffic areas. 2. Using light bed coverings and changing the linen often if the patient is diaphoretic. And 3. Encouraging and assisting with exercise involving large muscle groups. Tremors can interfere with small muscle coordination to allow the release of nervous tension and restlessness. It is important to establish a supportive, trusting relationship to promote coping by a patient who is irritable, restless, and anxious. If exophthalmos is present, there is a potential for corneal injury related to irritation and dryness. The patient may have orbital pain. To relieve eye discomfort and prevent corneal ulceration, apply artificial tears to soothe and moisten conjunctival membranes. Restricting salt may help reduce paraorbital edema. Elevate the patient's head to promote fluid drainage from the paraorbital area. The patient should sit upright as much as possible. Dark glasses reduce glare and prevent irritation from smoke, air currents, dust, and dirt. If the eyelids cannot be closed, lightly tape them shut for sleep. To maintain flexibility, teach the patient to exercise the intraocular muscles several times a day by turning the eyes in the complete range of motion. Good grooming can help reduce the loss of self-esteem from an altered body image. If the exophthalmos is severe, treatment options include corticosteroids, radiation of retroorbital tissues, orbital decompression, or corrective lid or muscle surgery. Thyroid surgery. When a subtotal thyroidectomy is the treatment of choice, the patient must be adequately prepared to avoid complications. Before surgery, antithyroid drugs, iodine, and beta blockers may be given to achieve a euthyroid state. Iodine also decreases the vascularization of the thyroid gland, reducing the risk for hemorrhage. Before surgery, teach the patient about routine postoperative care and comfort and safety measures. Show the patient how to support the head manually while turning in bed, since this minimizes stress on the suture line after surgery. The patient should practice neck range of motion exercises. Tell the patient that talking is likely to be difficult for a short time after surgery. Review the importance of performing leg exercises. Postoperative care. Postoperative complications include hypothyroidism, damage to or inadvertent removal of parathyroid glands, causing hypoparathyroidism and hypocalcemia, hemorrhage, injury to the recurrent or superior laryngeal nerve, thyrotoxicosis, and infection. Recurrent laryngeal nerve damage leads to vocal cord paralysis. If both cords are paralyzed, spastic airway obstruction will occur, requiring an immediate tracheostomy. Respiration may become difficult because of excess swelling of the neck tissues, hemorrhage, and hematoma formation. Laryngeal stridor, harsh vibratory sound, may occur because of edema of the laryngeal nerve. It also may be related to tetany from hypocalcemia, which occurs if the parathyroid glands were removed or damaged during surgery. To treat tetany, IV calcium salts, e.g., calcium glutamate, should be available. After a thyroidectomy, assess the patient frequently for signs of hemorrhage or tracheal compression. The patients should expect some hoarseness for 3 or 4 days after surgery because of edema. Keep the patient in a semi-Fowler position and support the patient's head with pillows. Avoid any tension on the suture lines. Monitor vital signs and assess for any signs of hypocalcemia from hypoparathyroidism. If recovery is uneventful, the patient ambulates within hours after surgery. Fluids are allowed as soon as tolerated. A soft diet starts the day after surgery. The appearance of the incision may be distressing to the patient. Reassure the patient that the scar will fade in color and eventually look like a normal neck wrinkle. A scarf, jewelry, a high collar, or other covering can effectively camouflage the scar. Ambulatory care. Teach the patient and caregiver that thyroid hormone balance will be monitored periodically. Most patients have a period of relative hypothyroidism soon after surgery because of the substantial reduction in the size of the thyroid. However, the remaining tissue usually hypertrophies over time and recovers the ability to make hormones. Giving thyroid hormone is avoided because the exogenous hormone inhibits pituitary production of TSH and delays or prevents the restoration of normal gland function and tissue regeneration. To prevent weight gain, caloric intake must be greatly reduced below the amount that was required before surgery. Adequate iodine is needed to promote thyroid function, but excesses can inhibit the thyroid gland. Seafood once or twice a week or normal use of iodized salt should provide enough iodine intake. Encourage regular exercise to stimulate the thyroid gland. Teach the patient to avoid high environmental temperatures because they inhibit thyroid regeneration. Regular follow-up care is needed. The patient should see the HCP biweekly for a month and then at least semi-annually to assess thyroid function. Tell the patient who had a complete thyroidectomy about the need for lifelong thyroid hormone replacement. Teach the patient the signs and symptoms of thyroid failure and to seek medical care promptly if these develop. Evaluation. The expected outcomes are that the patient with hyperthyroidism will have relief of symptoms, have no serious complications related to the disease or treatment, cooperate with the therapeutic plan, maintain nutritional balance.